Hello, everybody. I have the pleasure to host today on the IVF Worldwide webinar platform our friend Professor Bart Fauser, who is known to all of us. Bart is a professor of reproductive medicine, former head of the Department of Reproductive Medicine and Gynecology, and chair of the Division of Women and Baby at the University of Utrecht in the Netherlands. He is a fellow of the Royal College of Obstetrics and Gynecology, honorary member of the ESHRE, member of the National Academy of Medicine, member of the board of the Dutch Medicine Research Council, and executive board member of the IFFS. He was the editor-in-chief of Human Reproduction Update, and currently he is the editor-in-chief of RBM Online. Bart's major research interests include the pathophysiology of human ovarian function, PCOS, premature ovarian failure, IVF, and women's health. He has published over 450 peer-reviewed articles, and his work has been widely covered in the national and international press. And today, his presentation is about how to define a successful IVF program. Hello, Bart. But before we start with the presentation, I would like to take the privilege of being the host of this session and just have a short discussion with you to learn about your thoughts about a few things that I think might be interest to all of us. And the first one, can you please share with us the current situation in the Netherlands and if there are any fertility treatment like IUI, IVF, diagnostic procedure like hysterosalpingography or hysteroscopy?
Okay, in the Netherlands, we went through a quite difficult phase. Let's say the last 4 or 5 weeks, we have been updated by our Prime Minister 2-3 times a week, very, very serious, and we are in what he refers to as an intelligent lockdown, which means that we are allowed to leave our houses, but only, of course, certain jobs are exempt from that, healthcare workers, of course, but some others. But for the rest, we are all seriously motivated to stay home as much as possible. So only for shopping, for groceries, we are discouraged to visit our older relatives, our parents. Of course, next to older people, handicapped people are seriously endangered. I have a handicapped son, so that's something that I have to take care of very seriously. But these measures have been successful in terms of 3-4 weeks ago. People predicted that the whole healthcare system would go bust and that we would need many more intensive care units than we actually have, or that we could create new ones that we could create. So people were talking about 2,500 intensive care units for our country. That was the maximum it could be stretched, and that would not be enough. So there have been heavy debates and of course issues about money and building new intensive care units and having all the equipment being ordered abroad. But the good news is that over the last, I guess, the last week, we did not see a serious increase. So the number of intensive care patients diagnosed with the coronavirus is about 1,400, and it's fairly stable now. So of course people die, people are released from the intensive care. So over the last week or so, 5 days, we did not see a further increase. But still, we are pretty seriously hurt by this condition. The number of people who deceased from corona is considerable. But and the other issue is that we don't diagnose, don't test individuals systematically. So probably what we know and the figures we see in our national registries of corona-related death is a growth underestimation. And if we would look at reality, real life death related to corona, it's probably at least double the official figures. So again, the good news is it seems to be under control. The bad news is, of course, the economy, and the bad news is that people are getting impatient. 4 weeks in lockdown situation. So everybody believes that this is not sustainable for much longer. So how to try to find the right balance. And that certainly also relates to infertility care. In the Netherlands, it is not surprising when you know the Dutch culture that, of course, one of the first elective medicine interventions that can be stopped is infertility treatment or diagnostics. And that indeed has taken place about a month ago. So no infertility interventions whatsoever. And even now, today, even when people start talking about collateral damage, which other areas of medicine have been hurt by this serious corona pandemic, like oncology diagnosis, like kidney transplantation patients, like acute cardiac failure diagnosis. These has all been reduced to half over the last couple of weeks. And that's, of course, not because the disease has been less prominent, but it's just because people were afraid to go to the hospital, or they didn't want to have burden the system even further. So there has been a gross underdiagnosis. And certainly I've been trying in a subtle manner to bring infertility treatment in the, make people aware of that for some patients, there is no time left, and they cannot wait in terms of oncofertility, and certainly also in terms of the women with more advanced reproductive age. But until now, this is really under the radar, and what people say, because reproductive care or infertility care is usually almost exclusively done in hospital settings in my country. And one of the big arguments is, of course, resources. That the corona epidemic has been takes so much effort and so much people, and also in the triage, so that many doctors from other areas, including gynecology and reproduction, they got involved in corona care or corona screening. So they say, these people, we need these people to live up to expectations and to give the best of care to potential corona affected people. So it's a difficult discussion, and nationally it is slightly different, or internationally, because infertility care, of course, in the great majority of countries, is predominantly performed in the private setting. So there, the argument that you need these healthcare workers to help the corona pandemic being managed does not apply, because they don't work in a hospital setting. And there you see more and more people, and now also you have more and more patients and patient organizations that stand out and say, hey, this is also devastating for us, and let's look which kind of infertility care could resume, and when is this going to happen? So less stringent than Dutch national, less stringent than ESHRE and ASRM guidelines. But this is a difficult message for some. And certainly as a chief editor of the journal IBM Online, I've been following this closely. We received some commentaries. Actually, the first two were published last week. So if you're interested in the more concise way of evaluating the pros and cons and what can be done, what cannot be done, so you can read the two first papers being published on this topic last week in my journal. So it's a difficult balance, and for sure, of course, safety first in everything, and also in infertility care. And this, of course, involves safety of parents, so safety of the woman, the mother to be, but of course also safety of the child to be. And although initial observations reported from China, I saw a JAMA paper just released this weekend on children born from corona-infected pregnant women. It seems, I have to be careful, it seems fairly okay, so not no observations that would give rise to major worries. But still, of course, this is very, very preliminary. So nobody at this stage would make a plea for resumption of infertility care overall, or IVF for that matter. But you could think about oncofertility, cryopreservation of gametes, potentially embryos, that those activities could resume again fairly safely when you balance the pros and cons. And the reports in the international literature has been especially, of course, women in their late 30s or early 40s that were in the midst of an IVF treatment. And we can easily understand that the delay, which could last several months for those individuals using their own gametes, is not a realistic proposition. So we have to be very careful here in evaluating again the pros and cons in those particular circumstances.
Thank you, Bart, for sharing this information with us. And I want further to ask you another two questions. One is, as the editor-in-chief of RBM Online, what do you think would happen to all the current clinical studies that were stopped, and how this will influence future publications?
That's a very, very a good question, a very relevant question. Indeed, almost all infertility studies has been stopped throughout the world. So there will be, that's very costly, of course, to stop a trial. It will take a lot of extra energy to resume these studies, and also when can this be done? Probably the public opinion will say, focus on patient care first, and then wait with the reinitiation of trials. Of course, it will mean that certainly prospective trials submitted for publication will reduce in the next for the next 2 or 3 years. And also, if you think about it statistically, of course, having prospective inclusion of patients, respective patients, then you have to stop for a given period of time and resume after whatever, 6 months, 12 months. Also from a statistical point of view, this may be problematic. On the other hand, we have to realize that, in everything which is published in reproduction, in infertility care, it is still more than 90% of papers being published are retrospective analysis. So in that respect, it will affect high quality prospective science, but there will be enough issues to address for which there's no prospective trials available.
And before going to your lecture, just the last question. You're probably aware that we are doing quite a lot of surveys on IVF worldwide, and we noticed that current clinical practice is different from evidence-based medicine as published in the literature. And I will give you just one example. It's the use of progesterone. Just using progesterone to support the luteal phase and the continuation of the drug up to 10 to 12 weeks of gestation, where all studies show that it is not needed. You can stop administration progesterone when you have a fetal heartbeat. And the other thing is, there are lots of study and meta-analysis showing that there is no difference between the different formulation of progesterone. the IM, the subcutaneous, and now it's the oral. And still, people continue to use IM progesterone, which is known that which is very painful and low. The patients have local side effects, and it's very curious to know why there is such a difference between clinical practice and science.
That's a very good question, Zev, and I'm aware of that, and to some extent it relates to my presentation. I think in general we can say that the clinicians are quite well informed. They are aware of the well-designed, evidence-based RCTs, but I think consciously or unconsciously, people who continue with doing it differently than what these studies suggest is that these results are not relevant in their conditions. They are not relevant for their patients. And I think the word to be used here is context. That the context where they perform IVF or luteal-phase supplementation is different. And whether that's valid or not is an evaluation that we all have to make ourselves. But we have to realize that much of what we do is not based on evidence. And then, of course, you have to define the word evidence. What is evidence? And why is it relevant or not relevant in our particular condition? And again, I will probably address that in my upcoming lecture.
So thank you, Bart. And without further delay, you're most welcome to present your talk and slides now. Thank you.
Okay, Seth. So indeed, I was asked to talk about how to define successful IVF. And for the people that listen to this presentation, maybe this is the time to ask yourselves, how do I define successful IVF? What is the most relevant outcome measure? Because it seems such an obvious question. And at first glance, you may think, why even focus on this? It is so obvious. But when you start thinking about this, you will see that life is less unidimensional. And therefore, and again, it relates to the discussion with Zev previously, if you think about the way IVF is practiced throughout the world, we all know that there are major regional differences. So this already suggests that the way different continents in the world define success is not so unified. And why is that? And what does it mean? So how do you get a handle on this? How can you make it objective and concrete that you can say what should be modified, what should be the next steps? So, and I will try to take you through at least my world and my view on this, which I developed, let's say, over the last decade. And again, ask yourself whether this is relevant in your particular situation. So my disclosure statements, I will not go in detail. It has been mentioned in the introduction. I'm an emeritus professor. I'm involved in government bodies, in scientific journals, in executive boards of big in global organizations, consultant for pharma companies, and visiting professor. And let's start with a very, very concrete example. A friend of mine had to undergo knee surgery recently. And it started me thinking about outcome. So what would be an outcome, the desired outcome of knee surgery? And again, it seems very straightforward, isn't it? There is a problem with your knee, you cannot move properly, it's often painful. So you could easily think, how to define when a surgery is successful or not, isn't it? Okay, reality. What is an outcome for most of these individuals undergoing knee surgery. And again, my friend is one of them. He was very, very pleased with the knee surgery because after this, he's out of pain. For him, it was very painful, and he was very happy being relieved from the pain. Although still functionally, he could stroll a little, he can stroll a little, but not much. Again, he's a very happy patient. But other patients that undergo knee surgery, they are used to go jogging. That's part of their lifestyle. That's part of what they have been doing. And of course, in the extreme marathon runners, of course, if they would be relieved from the pain only, or maybe could stroll along a shopping mall on the Sunday afternoon, so the same outcome, they would be very unhappy. Because what would be a desired outcome for them is that they could go jogging again. So even something pretty simple as this, I think this example tells you that the individual expectations or desires of outcomes may be quite different. And even with the same outcome, some patients may be very happy, whereas others are not. So we have to manage this expectation and make it explicit. When you talk about outcomes, it's quite often that also when I lecture about this, people come to me and say, why bother? You know, who cares about outcomes? I can tell you that I think it is one of the major issues now in healthcare in general about outcomes. And there are many developments, and there are seminars and courses, health insurance companies, government bodies, they are all related to outcomes. Because why does a patient seek help from a healthcare system, and what do they want to get out of it? So when are they happy or not? And you have I think these are the three major developments now: the PROMs, the patient-reported outcome measures. This is very much in terms of health insurance companies. So this is very much, again, focused on the patient. What does the patient want, and how can we organize care around the desires of patients? Then, and this became almost a religion, the value-based healthcare. Porter is the name associated with that. You know, a lot of current healthcare managers and board of director members of big hospitals in my country, they went to Porter courses, Harvard in Boston, of course, and this is very much also focused on outcomes relevant for patients, but also the health economics aspect. How can we get there as fast as possible, as easy as possible, and as cheap as possible? So how can we reorganize healthcare around the desire of patients and get there as efficient as we want? And last but not least, and also it relates to Zef's question, why don't we follow what the guidelines or what the big RCTs dictate? Now we also live in the time of shared decision making, which means that we are more counselors, and together with patients, we jointly decide what is best for them, which again may not be the same as the outcome of a big sample-sized RCT. So how does this relate to IVF? And we all know this, the IVF league tables. I think this was the first publication. Can you see this? This is more than 20 years ago now in the British Medical Journal, where they compared live birth rates for all individual clinics in the UK. And of course, you can easily imagine that if you are somewhere around on the right-hand side of the slide, then you're very happy. But if you happen to be on one of the top clinics with a very low pregnancy rate, you have a lot of explaining to do to patients, and you may not be so very happy where you are. So comparing outcomes, okay, but of course the key question is, how do we do this? And there are many, many uncertainties around this, again, related to context. Which patients do you treat? which is the average age of your patients, and etc., etc., which all is related to outcomes and not necessarily about the performance of the doctor and the performance of the lab. There has been an interesting debate series on this in human reproduction in 2004. Very, very interesting. It started with a publication by from the Melbourne group in Australia, saying that they made a plea for using the BEST criteria, birth emphasizing a successful singleton at term. And it started the whole debate series. And you see here all the contributions in bold. It's ours. I'll tell you later about this. But the interesting issue is that after 1 year of debate on successful outcome, the editor-in-chief at that time, David Barlow, said, this discussion is leading nowhere. So let's stop from here. So not because we reached a consensus, but because it appeared impossible to reach a consensus. And I find this difficult to explain, for instance, to my lay public friends, my non-doctor friends, and they say, you know, how is it possible that for an intervention that you do, you cannot reach an agreement on how, what is the parameter that we should compare with? So what is the best outcome parameter? That's, again, difficult to understand for non-doctors. At that time, and I know it was pretty bold and certainly very, very few people agreed, we said that in terms of improving outcome, we should not look at surrogate markers, but we should look at the whole treatment. So an integrated approach of looking at outcomes. It's not the easiest way, but at the end of the day, we said at the time, it's the only way. And I think it's fair to say that in the last 15 years after that, developments are more and more going in this direction, which we reported in 2004. And when you talk about outcomes in more concrete terms, this is a publication from our quite controversial, international, esteemed peer, Norbert Gleicher. He published in Fertility Sterility a paper where he compared the registry data of IVF US and Europe. And his conclusion was, and it's shown here in the Bart slide, that pregnancy rates per cycle, live birth rates per cycle in the US was much higher in Europe. And he actually literally advised in that paper to consider for European patients undergoing IVF treatment to consider to have their treatment in the US because they said, you know, you have a 1/3 higher chance for pregnancy compared to being treated in Europe. And of course, first I was challenged by this, I have to say, in a way offended by this. So it got me thinking about what this is mean and is it really true? And let me start before I'll give you all different arguments that I have no reservation by agreeing that probably, certainly at the time, labs in the IVF gave better results than labs in Europe. And there are studies to back this up that this is indeed true. But, and I gave a presentation on this shortly after that, trying to digest what does it mean and what are the issues that should be considered. Now, the first one is the definition of live birth. I will get to that later on, but usually live birth is being used as a surrogate, so to speak, for healthy children. And I think that's wrong. That's not true. Again, I will get to that. Which patients are being treated? Of course, if you treat better prognosis patients, you will have better outcomes. And then it does not represent the treatment, but it represents the patient. And also patients' habits like smoking. You know, smoking in the US was banned at the time. And in those years, there were still about 15% of patients in Europe undergoing IVF who were still smoking. We all know that this is not good for outcomes. Now, how about multiples and fetal reduction, so embryo transfer policy? How about complications like OHSS? How about side effects, long-term risks, prior results? what is the start of cycle anyway, duration of the cycle, the cost of the cycle, and dropouts, relevant for cumulative outcomes, but not for single cycle outcomes. And again, all those issues I will address later on. But this was my first thoughts made public in a presentation in 2007. I think based on this presentation, I was invited at the Best of ASHRAE ASRM in New York just a couple of years ago to defend my standpoint. And this was in the US, of course, focusing on US. So how do you compare IVF in Europe versus the US? And I did my own analysis at the time. And you can see on the left-hand side, comparing US data, the most recent US data available at the time, that was 2012, European data, European registry, 2010, you know, published in Human Reproduction annually, and our Dutch registry data, 2013, just for reason of comparison. And when you look on your right-hand side, when you look at pregnancy rates per cycle, when you really see in the US, it is live birth per cycle. In the EU, that's how it's registered in the EU, clinical pregnancy rate per aspiration. And when in the Netherlands already at the time, which was single embryo transfer was widely applied. And and we know now for sure, but already at the time, we had many children born from frozen embryos, because of course, if you transfer less embryos fresh, you will have more added value of your cryo program. So when in the Dutch circumstances, when you compare fresh and frozen together, then you see that pregnancy rates are identical in the US, EU, and the Netherlands. And not surprisingly, when you compare multiple pregnancy rates in those years, in the US, it is much higher compared to Europe, and especially in the Netherlands. You see that at that time, nationally in the US, the multiple pregnancy rate was 5 to 6 times higher compared to the Netherlands. And today in the Netherlands, multiple pregnancy rate following IVF is 1.3%, so virtually non-existent. So you see it's the nuance, and it relates to how do you look at data, what parameters do you compare. Last year in my journal RBMO, we published the first data from the African content, from Africa continent on IVF. You see it's a publication from Silke Dyer, and I dedicated an editorial to this, that now, except for the Asian Pacific region, we have registries of IVF throughout the world. And I think we can truly be proud of that, because we were one of the best registered medical procedures in the world. So that's the good news. The not so good news is, and as you might expect, that all these registries, they look at slightly different endpoints. So apparently success rates and how to define success, we did not agree upon so far, and therefore registries are different. So for sure, it's a lot better than nothing at all, but of course it's also easy to conclude that we would gain a lot by defining success first, and then adjust all the national or regional registries, so that then we at least we have data that we can really compare in a reliable manner. And if you're interested, again, this was outlined in an editorial of mine last year in RBMO. So, other aspects of IVF treatment outcome. So different issues that I would like to discuss with you. So what are these aspects that I think are relevant and that should be considered in greater detail? Live birth. What is a live birth, and is this what we consider the best endpoint? How about cost of IVF and its implications? How about cumulative outcomes rather than single procedure outcomes? How to assess new intervention, because only if we agree on a definition of success, then we can assess improvement of outcomes by adjunct interventions. And I will go into this in a little detail. And then at the end, I would like to outline the more integrated approach, again, which we published for the first time 2004. So the international guidelines, I'm sure you're aware of the international glossary. A whole group of people, WHO involved. Fernando Zegers as the lead in this and is the first author of these publications. They have been revised for several years. I've been present at several of those meetings and discussions. The definition of live birth, I often ask when I give a lecture to the audience, what do you think live birth means? You have different opinions, but here what it shows is that live birth under these is now defined as a child being born with signs of life after 20 weeks of completed gestation. 22 weeks signs of life. And for the ones amongst us, there are not many probably, who are still involved in obstetrics or keep up with obstetrics, they know that this has nothing to do with a healthy child. I would say in most conditions, the best that could happen to a child born after 22 weeks of amenorrhea with evidence of life is dying, because the morbidity of the surviving children being born so early is tremendous, is really tremendous. So if we would define an endpoint of our interventions closer to a healthy child, would that not be a significant improvement? We should think further how that should be done. Of course, I have my own ideas about this, which I'm not going to dwell on today. I would only like to make you aware that I personally feel that live birth as a definition of outcome is not good enough. Then cost, and this was part of a mini review series published in Fertility Sterility, which I chaired, and I asked some people to assess global cost and affordability of IVF. And it's not surprising that they have done a pretty sophisticated, they didn't just look at the money, but they looked at affordability, which is the cost of treatment in relation to the annual income of people. And there you see that the affordability, if you compare, it's the arrows, the US and the Netherlands, that affordability of IVF in the Netherlands is tenfold better compared to the US. And we know that in the United States, IVF is very expensive. There are only very few states, it's increasing, but still few states where it's covered by health insurance. So therefore, it's only the couples that have quite a significant amount of money that can afford to undergo IVF. And therefore, even in the US, the uptake of IVF in the general population is very low, because very few people can afford it. And again, think about this, how does it relate to success? You know, if you have a very good treatment, which only very few people can actually get, is that still part of successful treatment, yes or no? And of course, that results in, money, of course, is the main driver for IVF being available. And this is also a paper from Silke Dyer and Human Reproduction, ICMART report on IVF in the world, and where you compare the number of IVF cycles per number of inhabitants. You see at the very bottom in this data set, Indonesia is the lowest, and Lebanon is the highest. But look at the amount, the difference. 16 versus almost 3,500. So there's a 1,000-fold difference of availability of IVF comparing the lowest and the highest. And of course, that means in the low, there's undertreatment. maybe in the very high countries there's overtreatment. Then, if we would agree on a live birth or a better parameter related to healthy children, then the next question would be, per what? Improved live birth per what? And I really would like to make you think about this in greater detail. In the earlier days, it was often pregnancies per embryo transfer. Of course, if you have two events that are very close together, your absolute number will be very high. If you talk about a positive pregnancy test per embryo transfer, that's usually very, very high, certainly if you transfer multiple embryos. But now I think it's more and more that people say, we look at per started cycle. So if you start with an IVF cycle, then you look at pregnancy. But then it's almost always, and I think certainly in the big regional registries exclusively, people look at pregnancy rates per fresh embryo transfer. And then of course you encourage multiple embryo transfer, because if you look at per transfer, for sure your pregnancy rate will be higher if you transfer 2 or 3 compared to 1 embryo. When you look at outcomes per fresh embryo transfer, if you would look at outcomes per cumulative embryo transfers from a single cycle and from the same harvest, so fresh and frozen embryo transfer, then you will see that cumulative outcomes are fairly similar, because you may lose a little bit on your fresh transfer, but when you cryopreserve more good quality embryos, you will have more added value in subsequent frozen thawed embryo transfer. So I think that's a major benefit from looking at it. So there's no incentive anymore to transfer as many fresh embryos as you want if you look at cumulative per harvest. But, and already we discussed this in 2004, why do we even look at a given outcome for a single cycle only? Why not do we look at outcomes over a given period of time when you start with a treatment? And again, this is still in IVF very, very uncommon, this way of thinking. So I would like you to understand the pros, but also the cons of cumulative outcomes. First, you have to appreciate where these cumulative outcomes that I showed you before here in the slide, and we all now are used to looking at these. This is actually coming from cancer survival curves. This kind of statistics, and therefore it's also referred to as life table analysis, Kaplan-Meier proportional hazard. And what this means is you start with 100% of patients, for instance, women with breast cancer, and then you look at survival 5 years or 10 years later. We all know this kind of statistics, and people evaluate different treatment interventions by looking at these 5-year or 10-year survival rates. And from a statistical point of view, when you start with this 100% on your left-hand side, only 2 things can happen in a survival curve, in a life table analysis. You either stay alive or you pass away. It's a black and white situation. You stay in or you're a dropout because you pass away, because you die. In infertility, it is very, very different. When you talk about cumulative statistics, you can drop out because you are pregnant, but also you can be advised to refrain from further treatment because you had a poor response and you have a poor prognosis. People refrain, they don't continue with treatment because of treatment burden and stress. People cannot continue treatment because they don't have the money. If you have to pay themselves, they move to other clinics, they divorce. So there are very, very diverse reasons for dropping out. And from a statistical point of view, this is called censoring dropouts. And how do you censor? Because you can imagine if you start with 50 patients and either you get pregnant or you're advised not to continue with the treatment, at the end of the day, all the patients that remain in your program will get pregnant, because if not, you kick them out. So this is a way to maneuver and to manipulate, if you wish, your cumulative outcomes. And therefore, people have introduced the term optimistic or pessimistic. And optimistic means that you don't look at the dropouts, you only look at the patients that remain in the trial, and then you get very high numbers. And pessimistic, in reality, it means pessimistic. If you start with 100 patients, you only look over a given period of time, which proportion of those patients did get pregnant. But again, this does not represent differences in outcomes. This just represents different in how you calculate cumulative outcomes. Please remind this. So here you see one example, a paper, a retrospective analysis in the New England, where they actually gave the data of a single center retrospective. And here you see, if they calculate in the optimistic manner, they come to a cumulative probability of live birth of 72% and conservative 51%. Again, this is the same data, but it's just calculated in a different way. We have done, I think, the first prospective randomized controlled trial where we compared two different treatment strategies, mild and conventional. I will not go in detail, but looked at cumulative outcomes over a given period of time. So we start with IVF. In the Dutch system at the time, 3 cycles were reimbursed. So we just looked over time in the mistake. This slide emphasizes that cumulative outcomes is used very often in other areas in infertility care, like polycystic ovary syndrome and ovulation induction. We have worked on this a lot. I will not go in details, but this gives you the cumulative outcomes of singleton live birth with ovulation induction strategies. And you see it goes up to 70–80%. Nobody questions these kind of data in the area of PCOS and ovulation induction. Everybody is used to look at cumulative outcomes. Also, when you talk about IUI or expected management, everybody is used to look at cumulative outcomes. This is a Lancet paper from a Dutch group where they compared hyperstimulation for unexplained. And here you see it is cumulative outcomes over time. No question about it. But in IVF, in this particular study that we published, we were heavily criticized by looking at cumulative outcomes in IVF. I still don't understand why, if it concerns IVF, all of a sudden people have a problem. So we said, this is how we designed the study. It was a prospective randomized comparative trial that we said, why not look at what's happening over a given period of time and not so much per cycle or per embryo transfer. So it's possible, it's feasible, and it has been done. A Lancet publication of ours. And only when you look at cumulative outcomes, you can also look at dropouts. We published this separately in Human Reproduction just 1 year later, where you see that 2 different interventions over time gives different dropouts because one treatment was more burdensome to patients than others. Again, no time to go into details, but I want you to make you realize that dropouts and why people drop out and when you can how to affect dropouts really also affect your cumulative pregnancy rates over time. This is another New England paper from the US group. This is SART data, and I only want to show you this to emphasize that next to the conservative live birth rate for cumulative treatments in the US, and you see it's about 55–60%, so not much higher really than in Europe, but also on your right-hand side, you see over the discontinuation rate. So this is dropouts, which is 30–40%. So in the US, 30–40% of women do not continue subsequent IVF treatment. Think about if you could reduce your dropouts, of course, that your cumulative pregnancy rates will increase. This is a very general way of looking at interventions, developments in medicine. I like to show this. I'm not sure whether you're aware of this, the Gardner hype curve. So when you come with something new, and of course in infertility we are more than aware of this, usually in the beginning there's a much enthusiasm. That everybody's saying, wow, this is something, you know, from now on we're going to really improve the care, the IVF care we deliver. But then after a given period of time, you'll have some reservations, and then at the peak of inflated expectations. I think it's beautifully put. And then usually subsequent studies show that it doesn't work or it's harmful. Think about the whole aneuploidy, embryo aneuploidy discussion, the PGTA. And then you have the disillusion is low, and then at the end interventions will find its way, or you know, at the end it will show that it's really beneficial. Some IVF examples: single embryo transfer. I think there has been delay and resistance from the very beginning, but now I think everybody agrees that this is a good way to go. Blastocyst culture, agonist bolus, vitrification. So there are developments that really can say, you know, after the peak expectations will continue to be high and accepted now. There are questionable developments, the freeze-all, alternative culture system, but also there are many developments that turn out to be not so very helpful in terms of improving outcomes. Time-lapse, PGTA, many add-ons, endometrial scratching. So this brings me to a very, I would say, contagious discussion about add-ons. I'm not sure whether you're aware of this and whether this discussion is the same intensity in different parts of the world, but certainly in the United Kingdom, this has been heavily debated. It turns out that also IVF is practiced in the private setting, predominantly in the UK, and many patients were advised and were to go for add-ons and were charged for add-ons. And the HFEA finally said, yeah, but can you charge for procedures where there's no clear evidence? And they came up with a strategy of a traffic light. So red means there's no evidence that is beneficial. Amber means conflicting, we're not sure yet. And green is that RCT has really proven that it's beneficial. And when you look at it, in the green line, there's none. So none of the add-ons that we advise to our patients quite often have been really proven. And we, again, have written an editorial about this, because it also means what is successful IVF, but also how do you measure improvements? Should it be RCTs only, or are other research methodology also suitable to improve, to study this? So I'm coming towards my conclusion, and it's not an easy message. I understand that. How should we define IVF? So I think we have to realize that it has to do with the numerator and the denominator. And there are many different numerators. We talked about it, live birth, and we should even maybe take it one step further and talk about term live birth. That would already be a major improvement, or healthy children. And then, of course, you have the discussion how to define healthy children. But then the numerator per what? Not per embryo transfer, not per oocyte retrieval, not per started cycle, looking at fresh transfer only. So now we are getting to started cycle, cumulative, fresh and frozen. But I would like you to consider to talk about outcomes per started treatment, so which might involve multiple cycles. When you look what we sort of did 15 years ago, but now in greater detail about the studies being published in terms of numerator and denominator, it is now shown scientifically. This is a systematic review. I really enjoyed reading this, published a couple of years ago, where you see the numerator and the denominator vary tremendously. So even in prospectively designed RCTs, there is very little agreement on how outcome of IVF should be assessed. So one step away from the data, we should find, in my view, an optimal balance in infertility care. This is for IVF, but other areas as well. So we should consider burden of treatment, safety of treatment for women and for children, this in relation to time to pregnancy, and next to that, in relation to cost and access to care. And my last slide, that we have to realize that the way we practice IVF is not just based on science, but based on context. Of course, if we are in the midst of the continent of Africa, if we perform IVF, compare that to the way we perform IVF, for instance, in a very competitive area like in Massachusetts in the US, of course, it is very different. And why? Because we assess outcomes differently. Do we focus on pregnancy rates predominantly? Is cost important? Or do we focus on safety and access to care? So I hope this sharing of thoughts has been useful for you, and please think about this yourself and make up your own mind. And thank you for listening.
Thank you, Bart, for an excellent talk, as usual. I tried to summarize a few of the comments and the question, and maybe very shortly, if you can comment on it. IVF is basically safety and success rate. What do you think about artificial intelligence and machine learning in the field of IVF? As we know, it's all coming in. And what do you think about the automated lab, as if we try to save cost and increase the safety of the procedure?
Well, that's a very good question, and I do have my own opinion on this, but don't ask me for the evidence yet. But I think the evidence will come. Number one, it will. I'm a strong believer of this development, and I think it's going to come. And I think 10 years from now, everybody will use it, and then it's a no-brainer. There may be some room for improvement of outcomes because it will make the treatment more consistent. Of course, in the beginning, it will be more expensive, but at the end of the day, it will improve health economics when you do it all, and it will certainly be more safe in terms of you control the environment better, you have a consistent system that is using the same algorithm all the time, and certainly with current technology and algorithms and artificial intelligence, of course, the system will improve itself. And then you can more focus on individualized, you can monitor the embryos with all the proteomics, so you can look at the quality of the embryos, you can assess culture media, optimize culture media, and how it affects implantation rates, pregnancy complications, children outcomes. So I'm a strong believer, but also I can understand it will take a while in terms of development, but also it will generate some resistance because it will take over a lot of the things that are done by hand now.
And another one, our clinic is composed of, most of our clinic is 40% of our patients are 40 age and above. And what do you think about age limit? Should this include any other parameters like AMH or FSH? And until actually, when should we treat the patients?
Ooh, yeah, that's a difficult one. I'm sure you're aware of that. I can only make some general statements. I think AMH may be of help, but we all know that it did not completely live up to the promise it had 10 years ago. So there are technical issues. There may also be difference in context. For instance, different patient populations throughout the world may have different AMH concentrations. There are assay issues, but overall, we know that we will have more and more women being treated for IVF with a more advanced reproductive age. I think the bottom line question is here as well, we should not dictate what to do. We should counsel and give realistic information about prospects and decide together with the patients what is most relevant for them. And I honestly believe that in many of those cases, oocyte donation should be a very realistic alternative. So in my view, the need for oocyte donation and the need for oocyte donors will increase further in the years to come.
Okay, Bart, thank you very much for your time. It was really excellent. And I hope that we'll be able to go back to normal life here in Israel, the Netherlands, Europe, and the rest of the world pretty soon. And thank you again.
Thank you, Zev, and thank the audience for listening. I would love to hear their feedback.